I have the unenviable task of interrupting these great conversations that are going on, which we encourage, but we also need to stay on schedule. So I'm going to keep talking until people start to move to their seats. And maybe Sarah can, and her panel can begin to come up to the microphone here. So I can name names because I know some people here, and you don't want me to name your name to get you back in your seat. But it's great that we got such a good start, and I think most of you are not talking about the baseball game or the NBA playoffs. Some are, I'm sure, but many of you are talking about what you heard this morning. Our next panel we've called Defining the Value Proposition of Continuously Learning Healthcare. And this is really a seminal issue in the entire workshop's agenda, especially as we move to issues like sustainability and CEO leadership. And I'm really happy that Sarah Greene is going to be both the speaker and the moderator for this part of the panel. Sarah is a senior program officer with the Methods and Infrastructure Program at the Patient-Centered Outcomes Research Institute, or PCORI. She's responsible for providing intellectual and organizational leadership for the program, primarily working with many of you here at Wardy's in the PCORNet program. So Sarah, the floor is yours, and Sarah will not only moderate the session, speak at the session, she will also introduce the panelists. So she's a triple threat today.
Well, hopefully not. Thanks, Eric. Great. So thanks, everybody. I'll be giving a formal presentation, then we'll have three speakers provide their remarks, and then we'll open the floor for discussion. Our panelists today are Dr. Thomas Graf from Geisinger Health System, who is the Chief Medical Officer for Population Health and Longitudinal Care Service Lines at Geisinger, and is responsible for a number of value-based reengineering activities and initiatives in population health, including bundled payments, practice transition demonstrations for CMS, and the Accountable Care Organizations portfolio. Following Dr. Graf, Rita Redberg from the University of California at San Francisco will talk to us about improving our ability to choose wisely. And Dr. Redberg is a cardiologist and professor of medicine at University of California, San Francisco. She's been there since 1990 and oversees women's health and cardiovascular services. And she's also the she's the editor of JAMA Internal Medicine and is spearheading, helpfully, the journal's focus on healthcare reform and the less is more sort of concept. So I'm sure that will come through in her remarks. And then following Dr. Redberg, Trent Haywood has joined us. He is the Chief Medical Officer for the Blue Cross Blue Shield Association, which is a national federation of 37 independent, community-based, locally operated Blue Cross and Blue Shield companies. And as the Chief Medical Officer, Dr. Haywood is responsible for the Office of Clinical Affairs, the Center for Clinical Effectiveness, Clinical Practice, and the Center for Clinical Value. So obviously a terrific panel will follow me. And so just to get started here with these slides going. Great. Thanks. And that's exactly what I was going to ask for next. Thank you very much. Okay, so it's sort of funny because half a life ago I actually applied for a job at the IOM when I was 15. And so, you know, obviously that didn't work out, but in the interim I've been working on a number of research networks, including the HMO Research Network, networks focused on cancer, and improving the clinical research infrastructure in general. So it's just sort of funny how things worked out. And to come here and speak to you today is just such a great opportunity. Just post-break quick poll. Got a couple of periodicals up here, 4 of them, and just a bit of interaction time. Show of hands quickly. If you had to, I'll go through each of these. If you had to pick one of these that you would say is the most influential, which one would you say? And so show me, if you would say JAM is the most influential, raise your hands on your daily work. Okay, how about modern healthcare? Okay, this is going the way I thought. Health affairs? Okay, and Harvard Business Review. Okay, great, thank you. So why does that matter? Who cares, Sarah? The clicker doesn't care. That was illustrated to show you that different things are important and valuable to all of us. And creating the space for learning and the will to change is going to stem from understanding what's important to the people you're sitting in the room with. Nobody raised their hand for modern healthcare, and about, roughly half raised for JAMA, and about half of you raised for Harvard Business Review. So I think it's really interesting to see that there's an integration of perspectives that's going to be needed in order for the learning healthcare system to truly become the norm and not the exception, as was brought up earlier. So I would submit to you that willingness to honor and integrate those perspectives is going to be a cornerstone of what we do. And I think the other thing that's important here is that maybe we need some more boundary spanners. I think the systems that have demonstrated a lot of success in learning healthcare systems have people that have a foot in both worlds, in the research and in the health system world. And so I'm going to try to do a few things with this talk. I'm going to try to unify us around a vision, not the vision, but a vision of continuously learning healthcare that probably builds a lot on what was presented this morning by our other speakers. We will begin to articulate the value proposition. Again, this is a process. This is not a one-shot. And together, I think we can contemplate what it will take, and our panelists will then have some opportunities to share with us through their case examples what's possible. You've already seen this graphic a little bit earlier. This comes from the paper that I had a lot of fun writing with Eric and with our colleague Rob Reed. This is the virtuous cycle of the learning healthcare system. And what you can see about it is that a lot of things. As David brought up, it has the components of the plan, do, study, and act cycle, the PDSA cycle. It's got the bidirectional arrows that show that there's a suffusion of practice in research and research in practice. But the other thing about this diagram is it's kind of messy, right? There's nothing super, unidirectional or linear, and it's cyclical, but it's not. It's got the extra arrows in it. So it's kind of difficult to think about what ladders up into this learning healthcare system. And yet we, the people in this room, need to be able to go home and speak to its value. And we need to be able to persuade all of our colleagues that this is the model, that is, this model for continuous learning works. It can demonstrate, help us get to the triple aim, or, the things that are important to the health system leaders. And so I'll try to briefly articulate the value proposition. Like I said, it's not the one and only value proposition. But before I do that, I thought it'd be helpful to step back and think about, okay, what goes into a value proposition anyway? And I pulled these off of Wikipedia, for better or worse. But I think that it's important to realize that there's two parts of this value proposition. There are the things that there's what it says, we believe, the people in this room believe that this is the value of a learning healthcare system. But if you look at these definitions, the pieces that I bolded are factors that are important to the customer. What are the customer's beliefs? How well do we know the customers? And I would offer to you that we are not yet completely clear on who all of the customers are and what it is that they want. And I like this graphic. It's a little bit cartoonish, but I think it does a nice job of illustrating what we could do in this learning health system mindset. There is a lot of urgency, trailing healthcare and in healthcare every day. But if the learning healthcare system, if this notion of continuous learning can increase the relevance of the work that we do, if it can increase clarity for decision makers and take down their anxiety and their distraction a couple of notches, then that's a win for everybody. And so it's an interesting anecdote. On my 8th day at Pecoria, I've been there since October. Before that, I was at Group Health with Eric. On the 8th day, I sat down and thought through, okay, why would people join up in PecorNet? This was before we knew who was going to be funded, before we knew we were going to have entire cities come to the table, before we knew who our patient partners were going to be. And I thought, there's a number of things that our stakeholders are going to want to consider and want to know. And so I started mapping out a couple of key questions that would help us speak to this value proposition. The first one is, what do our customers, what do our stakeholders intrinsically value? And then what will they need to invest in a learning health system? We talked a little bit earlier about the resources that need to go into this, both the human capital and the financial in some cases. And I think it's important to think about what they will get in return for their investment. I'm not sure if we've crafted that piece of it as crisply as we could. And anybody who is going to make an investment wants to know what the risks and challenges are in adopting a mindset like this, because really what we're talking about is a different mindset. And so in that 8th day, when I was listening to my colleagues in P. Cornett and the leadership, I started thinking about who are all the customers, who are all the stakeholders that we need to consider in this equation. This is just the world according to Sarah. You can feel free to dispute it. I'm not putting it up here so that we can parse it today necessarily. But I do think that there are at least 8 different actors that we would want to make sure that this continuous learning health system speaks to. And you can see them up there. They range from employers and purchasers to industry, the researchers, the patients. And the column shows those questions that I had on the prior slide. What do they value? What will they get in return? What are they risking? And just, again, kind of a hypothetical example, not necessarily intended to debate the contents with you, but to show the contrast. Employers care about total cost of care. The providers care about autonomy and their relationship with the patient. The patient, in turn, cares about that relationship with their provider and being able to live a life without the burden of illness. And stories matter, right-sizing premiums matter. So this is all over the place. And that is perhaps one kernel of why this has been a little bit difficult to make it the norm and why it is the pioneering path-breaking organizations that are having some success in this space, but that not everybody has gotten on the train. And so with that, I'm going to pivot a little bit and talk for a few minutes about what it takes to create the conditions for learning, because I think that's the other big part of all of this. If we do get to a compelling value proposition as out of the course of this meeting and the next meeting in June, how are we going to be sure that we can go home and have the conditions that support learning? It's not automatic. There definitely needs to be some sustaining features. I like this quote. This is from Michael Soman from Group Health. He's the president and chief medical executive of Group Health Physicians, because I think it exemplifies the tension. Wouldn't it be great to wake up every morning knowing exactly what to do next? In our industry, we have to be as certain as possible most of the time. And that's true whether it's about the clinical care or because Group Health is a health plan also about, what's our members' experience? How many members will we even have? But what we're talking about here is that going from a sense of knowing to a sense of wanting to learn and needing to learn. And so, the battery's dying in the clicker, guys. So I wanted to talk through a couple of prevailing organizational conditions that are going to support learning. We found these at Group Health in the Research Institute. But it really does require a commitment by the leadership to give people time to explore together, to discover together, and to share. There's actually even a space situation. I mean, if you're in a space where you can't possibly, you're flying from thing to thing and you don't have the resources you need, you don't have the opportunity to collaborate or the time to reflect, it's not going to support learning. And I think that, again, the organizations in this room exemplify the fact that learning is a core value that's appreciated in its own right. Not point, okay. And then individual attributes also exist that support learning. And this is where it gets a little tough, I think, because humility and self-awareness, tolerance for ambiguity, those kind of go against that principle of waking up in the morning knowing exactly what you need to do. Learning requires vulnerability, and I think we're often in a situation where that requires, potentially opening ourselves up. We don't ever want to look weak in front of our colleagues or vulnerable, but I think sometimes that's really necessary, and that was the experience we had in our learning health system, was that we really needed to open up and be a little bit vulnerable sometimes. I'm really glad that earlier in the session, the first session, the concept of failure was raised. I think Dr. Rohak raised that. Willingness to fail is essential. There are companies whose motto is fail fast and fail often. And I think that to the extent that we can create an environment that encourages sharing the missteps, interestingly, at the HMO Research Network conference last month, they had a celebration of failure. I think they called it the Biggest Loser contest or something. And they actually talked about the times that people were rejected with a grant or with a paper. And, that builds resilience. It builds adaptation. So I think we should, even though we're all sitting in a room with the deepest bench of talent in health system leadership in the country, we should not be afraid to show that vulnerability, because it's going to make us more resilient and more adaptive. There's no magic formula for this. Dr. Wong mentioned earlier that she was her trial was spurred along by the fact that Rich Platt and the HCA CEO were sitting together. So there's some spontaneity and some serendipity that is often a part of this. So, you know, we may not get to a tipping point because of any particular formula. We may get to the tipping point because we were sitting next to the right person at the right meeting when they were in the right frame of mind. So I've talked about the value proposition. I've talked a little bit about the internal environment that supports learning. I think we would do ourselves a disservice if we didn't think about the external market conditions. This is just a top-of-the-head list of the pressures and the levers that are exerting force on healthcare and healthcare research. You can look at the list. It's everything from consumerism to meaningful use. These are the things that system leaders have to think about every day. Researchers are certainly thinking about many of these things, the data and analytics work that they can bring to the table. Patients Like Me has a fantastic Data for Good campaign that I hope will help patients start to understand the value proposition for research. But I think putting it all together is the task ahead of us. And so watchful waiting, not an option. I like this quote as well. This is from Paul Keckley. He was the executive director of Deloitte Health Solutions. He says, the environment rewards leaders and organizations that are not paralyzed by uncertainty or uninformed about the fast changes or fearful of the spotlight. We have to be bold. We can't be paralyzed in the face of these unparalleled challenges, because I would say that they are unparalleled opportunities despite the high stakes. The CoreNet is going to be that change. We are not going to wait. The patients remind us every day that we cannot wait. We aspire to be a national learning network. We're hitting the ground at 150 miles an hour as we lay the road in front of us. And I think what I've seen already in PCORNet is creating this climate of trust and humility from the outset. We are purposely uniting perspectives of CEOs and patients to develop a compelling value proposition. And you know, like I said, we can't wait, and I'm going to stop there and turn it over to my panelists. Thank you. And I believe Dr. Graff is going to go first, and you can either stay at the table or you want to come up.